Okay, so I think Beryl has mostly said this is a study about SMS reminders for malaria medication completion. Beryl's already asked whether those are condoms. They're not. They're malaria medication, as per the title. So I'm not sure. So just to get the preliminaries out of the way, mHealth is super hot right now, and this study is exciting that we just got published in PLOS ONE because we have a statistically significant effect showing that an mHealth study is able to increase treatment completion of malaria medication. And I think it's important, especially as a proof of concept, and I'll come back to that. But so, really excited about the results, but I do partly want to say that I'm hoping what I can convey in this talk is that, yes, this is exciting, and it seems like this can be part of the puzzle, but only part of the puzzle, really, in getting people to use antimalarial medicines appropriately. And that even sort of a text solution, you think of a text message as, in this case, just being sent out from a computer, from a machine, is actually quite embedded in sort of the social relationships between vendors and patients and that kind of thing. So we shouldn't think of it as separate. I also want to point out that even though this is a fairly simple solution, or seemingly simple intervention, that it actually required quite a complicated experimental setup. And I will try to convey some of that to you, potentially without confusing you, but we'll see how it goes. I want to do my thank yous first, because they always get done. So the co-authors on the study are Julia Raithman and Gunter Fink, who are the PIs, and then Slava and I are also on there. This is Gunter, the first time that our text message system worked. Unfortunately, he jumped into a ceiling fan, but he's fine. This is Slava making sure everything's okay with the text message system during a power outage. So our study coincided with rainy season in northern Ghana, which is really good in terms of malaria cases. Not that malaria is good, but it was good for the study. It's also really bad for electricity, so there are a lot of sort of panic attacks. And of course, the survey staff, which was this study was implemented by IPA Ghana. We had a really fantastic field crew and team, and they deserve almost all of the credit for this. Okay, so without further ado, here's what I'm going to attempt to do in the next 30 minutes. To set up the basic problem about medicine's use and resistance for malaria, to introduce you to the research question, the context in which this is placed, and then the specific site selection that we did, to describe the intervention and then the experimental setup that went around the intervention, to talk a little bit about the measurement of the outcome, because it wasn't super straightforward, and then talk about lessons and results. So that's the plan. All right. So malaria and antimalarial medication. So malaria mortality is quite a big deal, depending on whose estimates you like, either coming out of Seattle or coming out of Geneva, anywhere between sort of 620,000 to 880,000 deaths per year. What's more clear is that about 90% of the malaria mortality around the world happens in sub-Saharan Africa. There's about 207 million cases occur each year, again, depending on your source of estimates. And in Ghana, which is the site of this study, malaria is fever, but that's often coded as malaria, is the top cause of outpatient visits, sort of across public, private sector, children, adults, everywhere. So it's an economic burden, a time burden in that sense, as well as being potentially deadly, especially for women and children. And then we have some issues around malaria medication. So most of the malaria medication that's been in circulation for the past 40, 50, 60 years, sort of since World War II, is becoming increasingly ineffective. So a lot of the parasites, the malaria parasites, are developing resistance to these drugs. So the drugs no longer kill these parasites. And more or less, there's one class of drugs that remain effective, particularly in sub-Saharan Africa, because there is resistance emerging in Southeast Asian cities. And that's artemisinin-based combination therapies, or ACTs. This is the Artemisia plant that provides the A in ACT. So the reason that some of these drugs are starting to lose their effectiveness, or at least part of the reason, is A, people use them when they don't actually have malaria, and B, they don't always finish their medication. And when you don't finish your malaria medication, it's actually very serious. It has both private and public consequences. So privately, you might start to feel better, your fever goes down, your aches and your pains go away, but you haven't actually cleared the parasite for your system, so there's plenty of opportunity to get sick again, so both morbidity and mortality. Publicly, if Beryl, because she can't even recognize malaria pills, doesn't finish her course of treatment, she only takes maybe 2 days, then the malaria parasites that are left in her system are actually those that are relatively resistant to the drugs or stronger than the drugs. Mosquito bites Beryl, sucks out those parasites, puts them into me. This is sort of a simplified version, but I think it works. And then, this is the beginning of the spread of drug resistance. So when you have a lot of people not completing, not clearing the parasites completely from their body, again, has a private cost, but also a public cost. All right? But there's been a lot of work, sort of both because ACTs are effective, but also to sort of rush against resistance. There's been quite a few things going on globally, and then specifically in Ghana, to try to increase access to ACTs. So chloroquine and SP and some of the other drugs that are on the market, people would really like to kind of try to drive them out and have ACTs be front and center. So in Ghana in particular, they changed their policy in 2005, 2006 to not only make ACTs the first-line treatment, but to make them legally available over the counter, which isn't to say that they weren't widely available or available in the private sector before, but now, since then, it's legally the case. Ghana is also one of the sub-Saharan African countries that's making a real push towards national health insurance. They started to scale up their universal health scheme, or their universally aspiring health scheme in 2007. So this means that the total cost of ACTs are covered both in the public sector and in registered hospitals and pharmacies within the private sector. So again, bringing down the cost of patients. And then in 2010 was the launch of the Global Fund Housed Initiative, the AMFM, which I believe Simon has also done some work on, or in the context of in Kenya, which subsidized heavily the cost of ACTs. So sort of in Ghana, you have this mix of the NHIS, the National Health Insurance System, bringing the cost down to free. This is bringing the cost down to about $1, which is not super cheap if you're on $1 a day kind of poverty line, but still significantly cheaper than they had been, which had been more in the $8 to $10 range. And I should note that this study that I'm talking about today was funded by CHI, the Clinton Health Access Initiative, specifically as an operational research project under the AMFM. But to come back to this, so we have this context of increasing affordability and availability, or access, and all of this raises more concerns about appropriate use then. Okay, and so the basic research question that sort of spawned this study was, how can we improve ACT completion, and particularly in the context of increased access? All right, so just to bring us back to the not condoms, you might be saying, Heather, you're making kind of a big deal out of this. This looks like it's a 3-day course of medicine that people have to take 6 times. That seems doable. This isn't HIV, this isn't diabetes. I feel like people can handle 3 days. So I'll sort of give away this now. In our comparison group, treatment completion is just over 60%. In a systematic review on ACT completion, it ranges sort of from 40% to 95%. Simon, I think at least one of your studies in Kenya looked like maybe you got reports around 70%. So, I mean, this is sort of what we're dealing with. So yes, it's only 3 days, it's only 6 times, but it isn't always happening, and this is sort of a big deal. All right, and so the more specific research questions we tried to ask in this study would text messages to patients improve completion. And the reason I emphasize to patients is that there have been a couple other studies in Kenya using mobile phones in the context of malaria, but more specifically to health providers, to get them to adhere to protocol. And this is really the first study looking at SMSs as ways to improve treatment completion for malaria in sub-Saharan Africa. So again, there's been 1 or 2 other studies about adherence to HIV treatment, but in terms of short-term medication, we sort of got the first. All right, and so the sub-questions to this is, will people actually enroll into a text message reminder system if invited? Can you keep the bright yellow ones going?
Yeah,
just keep passing them. And also, and will ACT vendors participate in sort of facilitating this enrollment? This is what we're going to use as the site of our enrolling people into the program and into the study. All right, so just to orient ourselves, I've been saying Ghana, so there's Ghana. For those of you who aren't so good on the country of Africa, it's still the no Ebola part of Africa, even though a Fox News study put our Fox News report put our study in Guinea. We're here in Ghana.
They put Guinea in Ghana.
They didn't put Guinea in Ghana, they put our study in Guinea, sorry. So Ghana is recently sort of reclassified for both statistical and actual economic reasons as a lower middle income country. It's malaria endemic throughout. 100% of the malaria mortality is caused by a particular species of the malaria parasite, P. falciparum. Here's a slightly closer up version of Ghana and its 10 regions. And we focused here in northern region and in and around the area of the capital of northern region, which is So Tamale is actually the third or the fourth biggest city in Ghana, depending how you count, with 560,000 people, which I think by Indian standards sounds quite small. In northern region, the urban transmission is moderate, rural transmission is high. Parasite prevalence in 2011 was around 50% among children. And the rainy season is May to September. And just to sort of jump ahead, our study spanned July to October, so we caught most of the rainy season. And why Tamale? So I mentioned earlier that this was sort of meant to be a proof of concept study. And so one reason, in general, the northern three regions of Ghana are significantly less developed on almost any welfare development indicator you can come up with compared to the Ghanaian average, so half the literacy, almost double the under 5 mortality. And so if we wanted to kind of show that this worked, and we did it down in the capital of Accra or down here, then everyone would be like, yeah, it worked there, but could it work anywhere else? So we kind of tried to go anywhere else. So that's why Tamale, so it was chosen to be a little bit more difficult. All right, so in terms of the basic causal chain of this idea, is that people go to a vendor, they get a medicine, and then they finish the medicine. That's sort of the working hypothesis. And when I use the word vendor, I'm talking about a range of different types of providers, from public and private hospitals, rural public health posts, private and public clinics, registered private pharmacies, and then down to what are called licensed chemical sellers, which are licensed to sell over-the-counter medicines, which, as I mentioned, legally includes ACTs. So this is a nice woman that, yes, I photographed, yes, I got her permission, yes, I asked her if I could reuse the photo. So this is just one example of one of these licensed chemical shops. Okay, so I've sort of left a few things out of the causal chain here. And one of them is, of course, that people recognize and act on the malaria symptoms and actually go to the vendor. But in this particular study, we did our recruitment of the vendor, so that first part is sort of preassumed. Then, in between someone actually making the decision to go to a doctor or a vendor, something, and actually getting an ACT course, that presumes that the vendor has ACTs as opposed to other antimalarials, that the vendor diagnoses malaria one way or the other, and that they actually give the appropriate treatment for the age and the body weight. So ACTs are supposed to be done by weight. But in this case, we sort of assume some of those things are set. So we make them set by design. So we mostly work with vendors who did sell ACTs. That was just a simple study design issue of really needing people to be getting ACTs. And so yeah, so that part was taken out. And again, we were only recruiting at vendors, so the whole part of actually recognizing that you have malaria and acting on time was sort of not part of our study, although a very obviously important part of getting here. And then there's this sort of black box between getting an ACT and completing an ACT. So we know that somewhere around 30–40% of people don't do it. Why not? So this is just sort of from literature and theory and anecdote, but one reason is that people might feel better. So the medicine actually acts fairly quickly to start to bring down your fever. So you might just be like, well, that's enough then. You might not particularly like pills or the side effects of ACTs. I'll come back to that. You might decide, so that picture showed before that an adult is supposed to take 4 pills at a time. You might decide that's not necessary for you or it's too strong for you, and you do your sort of saying that the medicine's too strong, so they take kind of half a dose each time. Something that a couple of the vendors kind of said to us is that people don't really take the drugs seriously, and so they don't really consider it to be dangerous or a bad thing if they stop early. And then there's some idea that maybe people save the medicine for sharing later or for using later. So that's sort of what's in this black box, and I'll try to open it up a bit later, but I can't say that we have all the answers there. Okay, so into that sort of space between getting your ACT and finishing your ACT is where we put our intervention, which is a text message that looks like this. So we actually had 2 different text messages, one that just simply said, please take your malaria drugs, another one that started with that and then went on to say, even if you feel better, you need to take all the pills to kill all the malaria. So we had a short and a long message. And just to give you an idea of what sort of the context in which we're doing this in terms of sort of health savviness, within our final study sample, which is 1,140, about 90% of people say that they have access to a mobile phone, whether it's not it's theirs, but only about 30% report sending a text in the past week. So they're kind of familiar phone, but it's not like texting all the time, like some of us do, maybe even across the office. It's certainly not quite like that. Okay, so the actual setup of the study was that we recruited, as I said, the vendors. And what we did was we asked the vendors themselves to have these flyers available. So I think many of you now have one of these bright yellow things. So we gave them a little business card holder, a flyer. We didn't give the vendors that much instruction. We basically said, this is, for patients who have malaria, and if they want more information about malaria, you can tell this to them. So some of the vendors just had these sit on their counter, some sort of more actively handed them out. And so then you might be wondering, well, how many people then got the flyer and how many actually then enrolled into your text message system? So we screened about 3,300 people for this study, so 3,300 people that had malaria. Of those, given sort of the way that we postally selected vendors, about 95% of those people were getting an ACT rather than another kind of antimalarial. So it's a bit of a skewed group in that sense. And then this is a bit of a shorthand, but between getting a flyer and actually enrolling in the text message system is about 63%. So I don't 100% know that for sure, because I don't know everyone that got a flyer. What I do know is that we had just under 1,800 people be eligible for our study, which I'll talk about in a little bit. And of those people that were actually eligible in our study, about 1,140 enrolled. So that's about 63%. So in terms of sort of first proof of concept, will people enroll in this? Especially, we very specifically, and with TRI's guidance, set out to make this a fairly hands-off experiment. So the surveyors didn't help with the enrollment or anything. So this is really people getting the card that either says, please text or flash this number for more information. And flashing is giving a missed call. So letting it ring once and you don't get charged yourself. Although you do have to have a credit balance in order to make that missed call, which is a little bit of a problem. So about 60 people actually take the plunge and enroll in our system. All right, and the randomization actually happens here. So the randomization happens once you get your flyer and you decide to make that call or text. From there, it's a two-stage randomization. First, into messenger comparison, and all of this is happening with the computer with the modem that you saw Slava saving earlier. And amongst those randomized to message, then there was another second stage of randomization to either the short message, take all your malaria drugs, and then the second one that went on to say, make you feel better, blah, blah, blah. So now in terms of the actual experiment timeline. So I should say, I thought that this was really impressive. Shagun was a little less impressed yesterday. So these are people who went into the hospital or a clinic, and either they're sick or they're buying medicine for someone else who is sick. And the drug vendor sort of tips off our surveyor, like, hey, that's a malaria patient, so they try to grab them on the way out. And then these people sort of sit down and talk to us and tell us about the medicine they just got and how much it costs, and we did a consent with them. So, if they were over 18, if they consented to potential follow-up, if the antimalarial they got was for an ACT and it was for either themselves or someone in their immediate household, if they had access to a mobile and they could give us that number so that we could match them later with the treatment. And if they lived within sort of a 30-minute motor ride, a two-wheeler ride of the center of Tamale, which Tamale, you get on the urban pretty quickly. So a 30-minute motor ride actually puts you out fairly close, in these movies. If you pass these things, then we tried to then ask you where you live. Give us a complete description of how to get there. Please give us your phone number. Please give us how we can find somebody else who knows you. Give us their phone number, but without trying to give any indication of when or why we might follow up. So we kind of said we might want to ask you some questions about your malaria treatment, but pretty careful not to mention anything about the completion of treatment. So trying really hard to avoid priming while having this sort of artificial conversation. And almost 1,800 people were eligible and willing to give us all this information about how to find them at any unknown time, which I thought was impressive. I will say that when we went back later to follow up with the vendors, about 40% said that questionnaire was kind of long, and the patients didn't really like it. We did try to keep it under 10 minutes, but describing where you live and then where your neighbor lives and then a couple other things takes a little time. Anyway, so once we got through that screening process, and we had enrolled you into the study, which again is separate from you enrolling yourself into the intervention, then began the countdown. So again, there's sort of 6 courses or 6 doses of medicine. So that's over a course of either 3 to 4 days, depending on if you start morning or night, and basically 60 hours. And so at about 60 hours, we wanted to be at your house. Surprise. And this is just one picture of a sort of rural-ish Ghana. So this begins our countdown. So we enroll people, we check to see if their phone number ended up in our system, but regardless, we did follow up with almost all of those 1,800 people. And we were really aiming for this sweet spot. So people should be finishing roughly 60 hours after we meet them with some assumptions about whether or not they took their first dose of medicine right when we met them or not. And so we wanted to hit them sort of in this sweet spot of between 58 to 72 hours after we had met them at the vendor, thinking that that was right about when they should be finishing their medicine. And I gave a shout out to the surveyors before, but I want to do it again because they had a 99% follow-up rate, and that was a lot of motor rides to a lot of houses that they didn't know where they were. It was a lot of going back, it was a lot of chasing people, and they did it, and they were awesome. So all the thanks to them. Then we get to your house, and we basically say, hey, can you go through your trash? So why do we do that? Because we're nosy? No, but also because there isn't really a good biometric for checking whether or not people have finished their artemisinin. So artemisinin just degrades pretty quickly in the bloodstream. There's no way of checking your blood and saying, oh no, you're only a 2-day person. So we have to rely on a detailed self-report and sort of an attempt to find evidence of completion. So we walk through with the patient, so the parent reporting on behalf of the patient if the patient was a minor. So we took them through sort of the 6 courses. Did you finish? Did you experience any problems? Did you vomit your medicine? Because that's sort of another way of non-completing even though you tried. And then we asked to see the empty blister strips. So that's another reason we really wanted to get there within 72 hours is in hopes that a completed blister strip wouldn't have been burned in the trash. And we also asked to do a full household inventory of medicines. Use this to sort of cross-check. And so this sort of combination of things and checking these against each other is what actually drives our outcome measure, which we do as a binary complete, non-complete. But again, it is based on self-report. And that's really the best we can do it. So of those people who were willing to report in one form or the other on completion, and that we were able to match with a phone number, either one they gave us at the vendor or one that they gave us later that they said to enroll, of the 1,800 people that we visited, or almost 1,800 that we visited their homes, the actual analytic sample is about 1,100. Yep. The analysis is pretty straightforward. So logistic regression, like I said, the outcomes binary, complete, non-complete. Fairly basic set of controls for patient characteristics, household characteristics, and the type of vendor where you were recruited. Standard errors were clustered at the vendor level. We also clustered them at the vendor neighborhood level, and at the household neighborhood level, the confidence intervals and the point estimates don't really change that much. Okay, so again, the headline result is this 5 percentage point increase from, particularly from the short medicine. So comparing the comparison group to the short medicine group, we see a 5 percentage point increase, which again is from 61.5 to 66.5%. The long message, it shows an increase, not statistically significant, and no, I'm not going to be able to answer why. So I'm sorry. We don't know. So a few things then that some of the non-enrollers told us about in terms of obstacles to enrolling. So about 30% said that they didn't have phone credit. And like I said, so a text message costs a few cents, and the flashing in should be free, but you do have to have a balance. And you know, most of these people sort of, this is a time and place of sort of the little paper strips where you sort of top up a couple dollars, a couple rupees or whatever at a time. A lot of them said, well, I wasn't carrying the phone that I have access to with me when I came to the vendor, and after that I sort of forgot or something happened. 14% said they didn't have time. This doesn't seem time consuming to me, but fair enough. They said they didn't have time. So in terms of sort of bringing something like this forward, I think the ideas of actually assisting people with enrollment and possibly covering the cost of enrolling into the text message system could be something to think about. All right. So these are reasons that people cited, not necessarily for stopping the ACT, but problems they experienced. Like I said, we walked through each dose with them. So about 20% of people say that they do feel dizzy, weak, or nauseated. 10% actually report stomach pains or vomiting. Another 8% say that they just really didn't like the smell of the taste of the pills, which are kind of bitter. Oh yeah, so one thing to know about ACTs is that they really go better with a heavy meal. And one other thing, in terms of all these sort of overlapping things that were happening in northern Ghana, is that this was also Ramadan. So the rainy season and Ramadan coincide. So people were sometimes fasting, and this, I don't think, helped things along. So it goes. And amongst those people at follow-up who hadn't completed their medicine, about 85% told us that they did intend to finish. We may have gotten there a little bit too early. Like I said, we were trying to hit that sweet spot, but we didn't know exactly when they started. Or they could just be being polite and saying what they thought they were supposed to say. About 8% said that they had planned to save them either to use themselves later in the household or to share sort of with family or friends. About 3% planned to throw them out, and everything else sort of planning to sell them or other things were under 1%. So that gets a little bit into that black box, but not a perfectly satisfactory picture. And then I think as Beryl had alluded to, then we went back after the study was completed to talk to the majority of the vendors who had hosted us. So some vendors, we sort of were there for like 4 hours and we said, you're really not moving any ACTs and we have to sort of consider our study sample size versus how much money we have to pay surveyors. So we sort of bounced. So anyone that we stayed with less than a day, we didn't go back to, but we tried to go back to most of the rest of them. 70, I believe we were able to talk to. And almost all of them, sort of without being directly asked, said that they would like to see the program continued. In their area, outside, other medicines, they had lots of ideas. Almost all of them wanted t-shirts as part of the scaling up, so that seems to be something to learn from. These are just, their perceptions, but about 20% told us that they thought their sales increased during the time that they were doing this. Quite a few of them said that the patients said that the patient actually came back to the vendor and said that they felt cared for. They really seemed to think that the vendor was the one sending these messages directly and they were feeling very loved, not that it was this computer that Slava was running. 20%, which is not necessarily overlapping with those that had their sales increased, had felt that their status and credibility had increased. Patients respect my advice more. Some of them said, I always tell them to finish their medicine, but now they sort of believe. Something else sort of interesting in the context of AMF is that quite a few of them, because of our studies, said that they started stocking ACTs when we're more variety, trying to keep them on the shelves, partially to keep our surveyors there, and partially because patients were coming back and actually sort of testifying, as they say, to the efficacy of the drugs or the effectiveness of the drugs. And then we asked them, okay, well, if you were interested in sort of seeing a program like this continue, what would it potentially take? So about 60% say that they would really need to find a way, they thought, for the vendor to be more proactive in enrolling and giving the patients education. Quite a few of them didn't really like the hands-off approach that we took. They would have preferred to sort of tell the patients that you need to complete your medicine and then explain to them what the text message was going to be, and then the text message would come. So again, we didn't tell the vendors that the main goal of this was treatment completion until these follow-ups. Before that, we were just saying it was information about malaria. 50% pointed out, well, I would need you to give me the flyers, I need you to give me phone credit, I would need those kind of things. And about 40% thought that they would actually need sort of a training course to be able to do this. Okay, so in closing, please, if you have malaria and you get an ACT, finish your medicine. I will hunt you down and text you. But no, more importantly, this is a 3-day, 4-day course of treatment. People don't finish for a variety of reasons, but they don't. And it's actually quite dangerous in terms of maintaining the drug that is available to all of us. As I said before, this study is about M-Health. M-Health is fairly sexy right now, and I think what we have shown is that it can potentially play some gap between once you access an ACT and then actually using it appropriately in terms of completing it. But this is still really embedded in social relationships, the relationship between the vendor and the patient, feeling like it's the vendor that's caring for you, and those kinds of things. And it's unlikely to get the job completely done. So yes, we show a statistically significant increase, but it's still less than 70% completion. So I think we need to be fairly honest about that. So a couple of the media reports are like, this is really going to solve the problem. It probably isn't. And again, sort of this simple hands-off text message that comes, somebody flashes, it goes to a computer, and the computer starts sending them text messages. That's about as simple as it gets. But actually, the sort of everything around it, the social relationships, the finding the people, then matching the people with the treatment because we didn't directly administer the treatment ourselves, that actually required a somewhat complicated experimental setup. It was definitely different than anything IPA Ghana had done before. They usually do sort of household-based or school-based questionnaires. You know where to find people, you know where to find people again. They haven't really done anything where you're just running and hoping that people give you good directions. The limited time frame sort of caused us several heart attacks, but I think we did a good job. And I think I said this before, but 40% of the vendors did say that the questionnaire was too long and patients were uncomfortable and didn't feel well, and could we please not do that again. So this is our wonderful back checker and auditor Swale, but overall that's what I have to say. So thank you, and questions, or else over to Simon.